Good afternoon, everyone, and welcome. My name is Ross Upshur. I'm a professor in the Dalla Lana School of Public Health and head of the Division of Clinical Public Health at the Dalla Lana School of Public Health. And I'm honored and privileged and pleased to welcome you to this webinar on ensuring global access to COVID-19 vaccines, which is co-hosted by the Center for Vaccine Preventable Diseases and the Institute for Pandemics at the Dalla Lana School of Public Health at the University of Toronto, as well as by UNICEF Canada. This panel discussion takes place during the World Health Organization's World Immunization Week, the Pan American Health Organization's Vaccination Week in the Americas, and Canada's National Immunization Awareness Week. So a nice confluence of occasions to celebrate today. So before we get started, I want to start with the main event. I'm going to start with an Indigenous land acknowledgement. I'll go over some housekeeping. Then I'm going to introduce the speakers, and then we'll get on with the main event. So I would first like to acknowledge the traditional territories of the Mississauga of the New Credit First Nation, Anishinaabe, Wendat, Huron, and Haudenosaunee Indigenous peoples on which the Dalla Lana School of Public Health now stands. The territory was the subject of the Dish with One Spoon Wampum Belt Covenant, agreement between the Iroquois Confederacy and the Confederacy of the Ojibwe and allied nations to peaceably share and care for the resources around the Great Lakes. We would also like to pay respects to all our ancestors and to our present elders. So just for housekeeping, we'll like to get, this is an obviously immensely important topic, and we'd like to get to as many questions as possible. Direct any questions that you'd like answered by the panelists, not in the chat function, but in the question and answer function. You can direct any questions you have after this webinar to this email address, cvpd.dlsph@utoronto.ca. And closed captioning in English is available during this webinar. Instructions on how to view the closed captions will be listed in the chat. And please keep in mind that this is an automated service, and we apologize for any errors made in the captions. So without further ado, it's my incredibly great pleasure to introduce our two stellar speakers. Our first speaker will be David Morley, and David Morley is the President and CEO of UNICEF Canada and is a prolific international speaker, commentator, and author, human rights advocate, and mobilizer with more than 30 years of experience advancing children's rights and sustainable development globally. He was appointed to the Order of Canada in 2018 and has been invested into the Order for his leadership in international development and for his humanitarian commitment to improving the lives of children and families around the world. David has also taught at the Monk School for Global Affairs and Public Policy at the University of Toronto, sits on the Advisory Council of the Institute for the Study of International Development and at McGill University, and is the co-chair of the Stephen Lewis Foundation. So a very distinguished presenter today, and we're delighted to have you with us. Our second speaker is Onome Ako, and Onome is the Executive Director of Amref Health Africa in Canada, the largest African-led international health NGO. In her role, she's responsible for leading the organization's strategic growth and innovative programming in areas which include maternal, newborn, and child health, sexual reproductive health and rights, adolescent health, and nutrition. She's got over 15 years experience in international development, and she has led initiatives in more than 15 countries with organizations including World Vision Canada, the Commonwealth, and UNESCO Regional Bureau for Education in Africa. She's the chair of the board of directors for the Canadian Partnership for Women and Children's Health and a member of the advisory committee for the Centennial College International Development Program. And in 2020, she was named to the Canadian Women in Global Health list. So two more appropriate speakers we couldn't ask. So I'm going to hand over to David, who will speak first, and then to Onome, and then I've got some questions to get them going. Over to you, David.
Thank you. Thank you very much, Ross. And it's great to see everybody today. And Onome, it's a privilege to be here on the panel with you. Thank you. I'm going to start by talking about the pandemic from our perspective at UNICEF, because this global pandemic has created a child rights crisis all around the world. And as I'm sure everybody in the webinar knows, UNICEF is the UN agency for children. We're active in every country in the world. We're the agency named in the Convention on the Rights of the Child, which itself is the most signed and ratified human rights convention in the world. So we have that responsibility. That's the lens we look through. And even though the COVID-19 is not causing mortality amongst children, as do many other diseases, it is having a terrible, terrible toll on children's lives. For the first time in 60 years, since we began keeping global statistics, the under 5 mortality rate is going up. It went up last year. Even during times like the financial meltdown, times when the global poverty rate has gone back, has not been declining, but has gone up, the under 5 mortality rate came down, not last year. As well, last year at the height of the pandemic, there were more than 1 billion children out of school, and many of those children have come back to school. There might be distance learning, but we know there are at least 200 million children who have not come back to school. And we don't know what the chance is going to be for those kids to come back to school. And of course, the poverty rate has gone up around the world. So those are all combining to make this a child rights crisis. Now, that has meant that UNICEF is part of the response. We have to be part of the response. And so we are active partners in the COVAX response around the world. We work with the WHO, with Gavi, to make sure that the COVID response, the efforts to have equitable distribution of COVID-related vaccines can happen. Our job is going to be, how do we turn vaccines into vaccinations? And again, why UNICEF? Because we know that most of these vaccinations are going to be going to adults first. It's because we are already involved in procuring and distributing and giving vaccinations to about 45% of the world's children in a regular year. All the routine 45% of the world's children who get routine immunization, it's because of the work that UNICEF does. So we can take those skills that we've had to develop in being such a deliverer of vaccinations for children and use those to become a deliverer of vaccinations for adults and for everybody in the COVID-19 response. In Copenhagen, in Denmark, is the world's largest humanitarian warehouse, and that's where our routine immunization, that's where the coordination happens from. And making sure through COVAX that equitable distribution of vaccines will happen, we're involved in the logistics, in the procurement of the vaccines, in getting them to countries. We work with the WHO to make sure that there's readiness in the country. Readiness can be everything from making sure that the airport, there are not going to be holdups at the airport when the vaccines come in, working together with ministries of health to ensure that the training is there, because it's different giving vaccinations to adults than it is to children. And so we're working on some of that training. We're making sure that the cold chain is in place, those logistics are there. And part of turning vaccines into vaccinations involves things like syringes. We have put in pre-orders for 2 billion syringes as well. I even heard a statistic that all the syringes that we expect to have by about the middle of next year, if you put them on the equator end to end, they would go 3.5 times around the equator. That's a lot of syringes. So as well as, of course, diagnostics and therapeutics, that's what we're involved in working with, and combating vaccine hesitancy, because that is still going to be extremely important. Working with local leaders, doing social listening, hearing where is vaccine hesitancy being promoted on the through social media, and then trying to respond through social media messages as best as we can to try and overcome vaccine hesitancy, because we know that is going to be a problem as well. Here in Canada, we have taken done some polling to see how Canadians feel about that. And if we could put up I can share the results. The polling's just come out. We did it not too long ago. And if that can go on the screen, thank you very much. This is to get a sense of what the Canadians feel. Next slide, please. So we saw that the sense of global distribution is extremely important, that as well as this, that 3/4 of Canadians recognize that mass vaccination is the only way forward. And that not only for us in Canada, but as you can see, 84% of Canadians felt it had to be done in all countries. Next slide, please. As well, we saw that the view of many of about 1/4 of Canadians who we polled, that their view of immunization has changed over the last year, and that we had 88% of those people who answered the poll said that their view of immunization for other diseases as well has become more positive, as we've heard talk time and time again over the last 13 months of the importance of the vaccines to end the COVID pandemic. Next, please. We're also seeing that 2/3 of Canadians are saying that Canada should be leading efforts, be involved in that, to make sure that there's vaccine equity around the world, to make sure that this will happen. Next, please. And that sense that 80%, 8 out of 10 Canadians agree that Canada should donate its excess doses of the vaccine to developing countries. But that is after, of course, that people feel that after they feel secure here at home. Next, please. And there's a broad recognition that when we have pediatric formulations, that it will be important for children to be vaccinated as well. So we're seeing positive signs of Canadian acceptance of the importance of vaccinations that are going to be things that we need to build on, I think, here in Canada and around the world. Next, please. That's the end of the slides. Just to say that we know, for us at UNICEF, as well as tackling the pandemic, we still want to be able to deliver the routine immunizations, to carry out all of the other programming that we do. We need to finish this job while we're doing the other job. But when we finish the COVID job, then we'll really be able to do our best to help ensure that children's rights can once again be protected and promoted as they should. Thank you very much again, Ross, for this opportunity. And I'll hand it over to you, Onome, I think. Over.
Yeah. Thank you, David. Onome, over to you, please. Thanks for a very illuminating discussion.
Thank you, David. That was amazing, and it's such a privilege to be sharing the stage with you as well. Thank you, Ross and team. Thank you for convening this extremely important conversation, especially during this week. So Amref Health Africa is African-based and African-led. We have our global headquarters in Nairobi, Kenya, with over 60 years of experience working in partnerships with governments, with the community, addressing the most pressing health needs. So we really have been engaged with governments and communities around conversations on vaccine equity. And so today I'd like to share two perspectives. And David, you've already spoken to some of this. So the two perspectives will be, one, how do we ensure that the vaccines are getting to the ports, one? And then my second perspective is really ensuring that the vaccines are being administered. So when they get to the ports, how do we ensure that they're actually getting into people's arms? Can I have my slide up, please? Thank you. If you can move to the next slide. Thank you. So on the far right of the diagram, it's a diagram from The Economist. It shows when various parts of the world are expected to have enough vaccine supply to reach herd immunity at around 60 to 70%. So you can see that the prediction for North America is to get the vaccines by late 2021. Right, you can see that in the dark green. I'm hopeful that I will receive my vaccine in the coming weeks. But for many Africans, this is not the case. As you will see from the diagram, vaccine coverage based on supply is not expected until early 2023 in Africa. So that gives a gap of at least 1 year, probably more, which is far too wide to control the pandemic globally. So we urgently need to close that gap and ensure that vaccine supply is more readily available to countries in Africa. So we're going to need about 1.5 doses for the continent, and our supply currently is around 36 million for a population of 1.3 billion. So why are there not enough vaccines for the continent? One, lack of the manufacturing capacity. Africa has a very limited vaccine manufacturing capacity of just about 1%. So basically, we actually import 99% of the vaccines that we require. The second is the cost. The high income countries have a greater ability to sign purchasing agreements for vaccines, while most countries in Africa cannot do that. Ross, at the beginning, we talked a little bit about COVAX, and David as well, you mentioned that in your presentation. COVAX limits, there's a limitation of just for 20% of a country's population. So COVAX alone cannot solve the vaccine supply issue. And lastly, something really important, again, that David mentioned is that Canadians want to see themselves vaccinated, but at the same time, a lot of countries, high-income countries, are taking more than their share of vaccines. And so there's a global shortage of vaccines. So there are key recommendations that I would like to make, but in the interest of time, I will just highlight the fact that we need to continue to advocate for global vaccine solidarity by supporting policy reforms and engagements to promote vaccine equity for the achievement of herd immunity, leaving no one behind. We know that COVID-19 anywhere is COVID-19 everywhere. The second point I would like to talk about is what happens after vaccines have been delivered. How do we ensure that everyone, irrespective of their gender, their socioeconomic status, their religion, location, have access to vaccines? So you will see to the left of my slide that we have 36 million available vaccines for the continent, but we only have 15 million that have been administered. That is less than 50%. Now, this equates to 0.8% of the population that has one dose. And for two doses, only 0.3% of the population. And majority of these are actually in Morocco, they're in one country. In North America, we've reached almost 30% for both vaccines. And in Canada is at 2.8%. So we know what the challenges of equitable vaccine distribution within countries are. And David, like you said, UNICEF is doing some work on the cold chain storage infrastructure, But there's also the challenge around fragile or non-existent primary health care on the continent. But we also know that there have been reports of expired vaccines in countries like South Sudan, in Malawi. DRC is also going to send some vaccines back to UNICEF. And we know, from news from colleagues that there's some vaccines also being sent back from, some counties in Kenya back to Nairobi. Why is this the case? And this is where, again, I would agree completely with David on the issue of vaccine hesitancy. We've recently completed research in Kenya to get better understanding of community health workers' knowledge of COVID-19 vaccines, as well as vaccine hesitancy amongst community health workers. Why community health workers? Amref's primary focus is on communities, and bridging the gap between communities and the formal health system is essential in reaching everyone, everywhere. And one of the ways we do this is through community health workers. They are the trusted source of health education and information in communities where we work. And we've learned from the Ebola pandemic in West Africa, Lassa fever in Nigeria, and our work during other epidemics on the continent that trained, knowledgeable community health workers are essential to the uptake of vaccine or other public health measures. And so we know that understanding vaccine hesitancy among community health workers is important in designing interventions to improve their effectiveness in mobilizing communities for vaccination. Can you please go to the next slide? So I'd like to share very, very quickly highlights of the study that we conducted. It was targeted to 4 counties, rural and urban in Kenya, reaching over 400 community health workers. And we really sought to understand the extent to which community health workers surveyed felt informed enough to engage with community members on the COVID-19 vaccine. Next slide, please. So as you can see, 50% of community workers, health workers, do not feel informed at all. And 37% felt informed just to a small extent. So that really leaves us with 80%, over 80% of community health workers not being informed enough to engage the wider community. Next slide, please. So we also found that the community health workers have varying degrees of knowledge on who is eligible for the vaccine, with about 36% saying that the vaccine was meant for both children and infants, including adults, so for everyone. You can see that in the G here. We also found significant difference in acceptance based on location. Like I mentioned earlier, we had urban and rural areas, and both Nairobi and Mombasa are urban areas, yet there's significant difference in the level of vaccine hesitancy. We found that community health workers who have had experience already engaging with communities on COVID-19 prevention are more likely to report that they're confident in engaging communities on vaccine. Next slide, please. We can go to the next slide. Thank you. So the other piece I wanted to raise is the acceptance of the vaccine by the level of education. We found, you can see that in blue, that everyone, all the community health workers that had no education was hesitant, right? Those with primary education were okay, but then the data shifted and we found that those with post-secondary education also became more hesitant. So going back to what David mentioned around access to technology or social media for the post-secondary, those that had post-secondary education. But what we also found was that there was really no significant impact based on sex age, or religion. So what's the study telling us? Or how does it guide our thinking about vaccine equity within a specific country? Importantly, the data suggests that hard to reach is not only a geographical issue when it comes to COVID-19 vaccine uptake in Kenya. Oftentimes, the global health community creates programs to reach the last mile that focus on areas that are physically difficult to reach. So with COVID-19 vaccines in Kenya, hard to reach could also be more about trusted information available to people about the vaccine. So as a colleague of mine said, COVID-19 in Kenya could easily become the disease of the illiterate. So I would like to end very quickly on 4 quick recommendations based on our learning. So when we're thinking about engaging with communities on vaccine hesitancy, 1, we really need to develop and implement community COVID-19 sensitization based on individual communities and not treating the whole communities as homogeneous. 2 is ensuring that community health workers are at the center of training. We're ensuring that we're training community health workers to reduce their own hesitancy, and then they're going to be ready to lead community engagement. The 3rd piece is around developing curriculum for training, ensuring that there are resources available, and fast-tracking training through innovative technology. And then finally, enhancing engagement with community health workers to increase trust with Ministry of Health around vaccine messaging. We noticed from the survey that a lot of the community health workers that showed hesitancy in vaccine actually did not trust the Ministry of Health. And so we really need to enhance this engagement as well. I'll pause there, Ross.
Thank you, Onome. So we've had 2 fabulous presentations, and now I'm going to try and focus the discussion a little bit. So our title is to talk about global vaccine equity, and both Onome and David have mentioned this mysterious new entity on the global health landscape called COVAX. So for those COVAX is part of what's called the ACT Accelerator, access to coronavirus tools. It has a vaccine arm, which is COVAX, but it also has a diagnostics, therapeutics, and a health systems arm as well. Canada has been a major contributor to both the ACT Accelerator, giving money for distribution of diagnostics and proven effective therapeutics. But it's also played a major role in the COVAX facility. And the COVAX facility itself is a complex entity. So this product, it's a kind of multi-stakeholder process. COVAX itself is led by CEPI, Gavi, and the World Health Organization, but it's using the incredible network that UNICEF has as a sort of delivery partner. So first question I'm going to turn to David to ask is to talk us through about how vaccines get delivered through the COVAX facility and who are the recipients. And then I'm going to turn to Onome and ask how well she thinks African countries have been served by COVAX so far. So over to you, David, please.
Oh, thanks, Ross. So the COVAX facility, we've our role maybe where, maybe UNICEF's role is a very Canadian role. It's almost being hewers of wood and drawers of water, because we're taking the vaccines. Because we procure so many vaccines, Gavi purchases the vaccines, but we do a lot of the actual procurement, the negotiating with the pharmaceutical companies, mostly these days, a lot with AstraZeneca. WHO has to approve the vaccines, first of all. Those are and same with any diagnostics that we're, or other therapeutics that we're sending. They have to, WHO is sort of serving like the FDA in the United States. That's what, those are the products that we're using. And then we use our regular channels that we do when we are of logistics support. We have lots of contracts with different airlines that are going to be taking the vaccines to different places. As well, we have our knowledge for how do you get through airports and into the countries. And then we're working together at the level of ministries of health. And what Onome said, I think, is so true, because the people who we rely on for our regular the routine immunization as well are those community health workers. They're the people who are actually doing the delivery, making sure it can happen, that have the local knowledge and ideally have enough of the know what they need to do to be able to give the immunizations. It is different. That was fascinating, that study, Onome, to see a microcosm, because I'm sure it's repeated in many other places, and it shows how much work that we still need to do to be able to make sure that we can do a better job or better empower the community health workers to do better.
Onome, would you like to comment on this?
Absolutely. Absolutely. So your question was, how well is COVAX working for us? And I think I did, in my initial reflection, said COVAX is only going to cover 20% of the country's population. So it's actually not cutting it for us, right? So the question, that I'll actually now think of is, what role do African governments actually have to play? I did mention that we only have 1% of vaccines manufactured in Africa. So we really need to start thinking about, local manufacturing of vaccines. That's really, really critical for us. And this is an area that Amref Health Africa has been working on, just to engage governments at various levels. So one, there needs to be an increased investment in health, research, and development, particularly in the areas of capacity strengthening for health researchers, innovators, and institutions, by ring-fencing R&D in budget allocations and support creation of manufacturing hubs under the leadership of the Africa CDC. So that's number one in terms of what African governments can do. Two is providing an enabling policy and legal environment to harmonize and improve efficiencies of regulatory reviews and approval of health technologies and medical products across the continent. Going back to what David said, we need to engage civil society to develop people-centered prioritization plans to guarantee in-country equity access in vaccines and availability to all citizens, including hard to reach. And hard to reach in terms of location, or hard to reach in terms of the kind of information that is coming to them. Again, the question rhetorically, why did we have vaccines from DRC now being returned? What were all the environment to ensure that the vaccine was moving from the ports into people's arms? And then I'll say the last thing I mentioned as well is strengthening that information flow from Ministry of Health. The Ministry of Health taking leadership in communication and dispelling the myths around COVID-19. It's extremely important. Where does the community or the citizens get the information from? It needs to be from one source. So COVAX alone is not going to solve it for us. There really needs to be leadership as well, taken from both an African, but also a global perspective.
Thank you, Onome. So the questions are coming in fast and furious now, and they're going in as we start to peel the onion skin of this complex landscape. So I'm going to ask questions and take us in two directions with questions to each of the panelists. So I'm going to start. So we are talking about global health, and it is a celebration of immunizations this week. So first, David, what has the impact of the pandemic been on the distribution of the other childhood vaccines, as well as vitamin A distribution? And just before you answer that, I'll give the question that'll come to Unome next, because it will pivot over to another topic, and it picks up on something you were saying, and I'll give you a few minutes to talk about it. To what extent is there a need for IP waivers to enhance vaccine manufacturing capacity globally? So first to David on the other vaccines, and then to Unome on IP waivers.
We're finding that I don't have statistics to be able to say, the numbers for routine immunization. We know that has all been affected. It's been affected because of, from the front lines, the concern that community health workers who deliver so many of the routine immunizations for social distancing, for protecting themselves, because when there isn't enough PPE in a country, has happened at the beginning of last year and can continue to have shortages, they're not going to be doing the same delivery. So that's why we're seeing, routine immunization is one of the most important reasons that the under 5 mortality rate has gone down year over year over year. Those immunizations that we give to children, it's not the only thing, but it's so important. So when that gets stopped, that has a driver of why more children died last year under 5 than did the year before. So we're seeing those slow down. And that's part of why we have to get to a point and do better. I absolutely agree with you, Unome. We have to have better results than just COVAX. It's COVAX hopefully can get things started. And we're working together on other ways, as not only with COVAX, because until we get the pandemic under control, the other routine immunization are not going to be able to come up. And we're also, because the focus of all of the logistics that's going into COVAX as well is another thing which slows down for everybody getting out the routine immunization. So we're trying to do 2 things at once, but we've got to be sure that we do a better job and that we're all able to work better on to get the immunization we need for COVID against over.
Thank you. And Unome, your thoughts, you can pick up on what David just commented on before you dive into IP waivers, if you wish.
No, I'll just, completely agree with what David said, to be honest, and probably move on to the question on the IP waivers. So could you ask, I'm just trying to pull that question right now, are there the manufacturing facilities? So, I will say the African Union and African CDC, they're actually in conversations right now, just in terms of the need, for manufacturing in Africa. But I think that, one thing I will say just in relation to the role that pharmaceutical companies can actually play is, increasing availability of vaccines to low and middle income countries at affordable subsidized prices, and then considering waivers or subsidies of intellectual property protections for COVID-19 technologies. So again, this is the conversation that we're currently having even within Amref with some of the private sector there that we're working with. So I will kind of leave it at that.
Thank you. So one question that has come in that's a very interesting and important question, and I'd like to get your thoughts on. So the whole ACT Accelerator COVAX was not meant to be the creation of a new institution with an enduring constitution. It's meant to be time limited. But as Unome's slides quite clearly showed, the rollout is going to take a considerable amount of time, which means that it's not just the manufacture of the vaccines, but a continued investment in procurement and day-to-day delivery and communications, et cetera, et cetera. So what do you think civil society organizations, other governments can do to create more flexible arrangements to assist LMICs to meet these operational needs?
Do you want to go, Onome, or I can try?
You can try and then I'll go after you. That's okay.
Okay, great. Yeah, fools rush in. Here I go. One of the things I think that is gonna happen is what if we start to need year after year booster shots? So Ross, I'm not trying to avoid your question, but to me, it's another thing on top of it. We're starting to hear, okay, maybe we'll need booster shots in a year, say, just for us in North America, because we don't know how long the efficacy will be. And then, as you say, we were not expecting COVAX to be something for permanently, but it may become something like that if we just need an entity that's going to be concentrating on COVID, and if we don't follow up enough, all of the variants. That's another reason why we need to move faster than we're able to at COVAX. And that also means some of the vaccine nationalism has to stop, that we have to find governments, as you were saying, Onome, that are willing to share more. Unfortunately, at a global level, sharing is, maybe we do it at an individual level. It's a lot harder to do. It doesn't seem to happen as easily at the global level. So we need to set some rules in place that will encourage that, even if it's in our self-interest. And with vaccines, it's just more complicated, I think, than than other drugs, because there's also nationalism on, if you don't manufacture syringes, what if I want to keep all the syringe manufacturing myself, or I'm going to be charging on other things which are not medicines but are part of the delivery? So Ross, we got a long way to go, but I think we could well see COVAX morphing into something. It might be an arm of Gavi, perhaps, because there's going to be need, I think, in the years ahead for further work on this to keep the pandemic down. Over.
Thanks, Tim. Onome.
Yeah, absolutely. So 2 things I'll say quickly. And I might not have the data completely right, but for every dollar that it takes to get the vaccine for every dollar you spend on the vaccine, it takes probably $3 to $4 for the actual delivery of the vaccine, right? So when you're looking at it from the cold chains, from the ports to the arms, it takes an extra $4, right? So the question then is, what is the level of investment in country and from development partners to ensure that those $4 are available for investment, to ensure that you can have the vaccine in people's arms? So that's the first thing I'll say. The second thing I'll say is also about the systems, right? The healthcare systems that we have, they need to be strengthened. So that's the bottom line. If you have a strengthened or a strong health system, then you're going to overcome a lot of these challenges. Then, David, to one of the points that you raised around, this might be an ongoing thing. Another area of investment that is still part of the whole strengthening of the health system is data. How do you follow person A that has gotten the vaccine and is living in a remote community? How do you ensure that they get their second shot? If, as you say, David, it's going to be, you're going to see us needing booster shots. That is going to be a huge challenge that we're going to have to overcome. And it's going back to the health systems and the fact that beyond COVID-19, our health systems in Africa really need to be strengthened.
Absolutely. So I'm going to take chair's prerogative here and ask a question of both of you, one that's really exercised my mind, because I've been working with the World Health Organization on, so we talk about equitable access. The COVAX formula said 20% across the board. That strikes me more about equality than equitability. And if in fact we're moving, and they've also altered their language to talk about ending the acute phase of the pandemic, which means they're envisioning a chronic phase to be following, as we've already sort of tipped our hats towards. So what are your thoughts around this? So equitable being equal. And once they made the allocation decision, it was for healthcare workers and basically those who are at highest risk of mortality. Is there any sense now in thinking a little differently now that we've had a year's experience with this virus about maybe equitable being a bit more priority to the most disadvantaged health systems? Any thoughts on that? I'll turn to Onome first and then come to Dave. Oh, you need to unmute. Or David, do you want to handle the question?
So,
oh, there you go. Sorry.
Go on.
Sorry, my mouse was, we had this conversation before the session. So I'm Nigerian and I have a lot of I'm Canadian as well. I have a lot of my, friends or people that I know that have been vaccinated. And the question that I ask is, are you a priority group? And so it begs the question, who is having access to vaccines, right? So in various countries, you have, access to the healthcare workers, to over 70s or, as we have here in Canada. But the question is, if I'm saying that to get the vaccine in Nigeria, in Kenya, or in Ethiopia, you have to register online. How do you ensure that a 70-year-old man in a rural community has access to the internet to actually register to get the vaccine? So to answer your question, Ross, I think that there really needs to be, a rethink or plan on who is a priority and what are the ways in which your priority population has access to the vaccines. If someone is living in a remote community and cannot go to the health facility, how do you ensure that the vaccine goes to them? And this again is one of the reasons that Amref Health Africa actually works through community health workers, because community health workers know the individual households that they deal with, and then they will be able to understand the challenges in access to the vaccines. So for me, it's again, working through people, boots on the ground, community health workers, and bridging that gap between community health and the formal health systems.
Thank you. David?
Ross, I think that's a difficult question. I mean, you do work with the WHO, so you know some of the issues. And I do think that the sense, the target of 20% of the population in the countries that it's a good start, but it's only a start. Then it's working with the governments, the ministries of health, to see who within, and encouraging within the countries where how the 20% might be distributed to go to more at need places. But for us, at UNICEF, we have been advocating not for, one specific group that we've been advocating for who should be vaccinated to get better, to help the economy, are teachers and people who are working with children, right? So that the education can open up again. And we think that can have a multiplier effect on reducing the impact if we can get children back in school and if teachers feel safe. Over.
Thank you. That was a question I was going to ask you about why UNICEF made the call to governments to prioritize teachers with vaccines, so you anticipated. So we're getting close to coming to the end. So I'm going to start with a few, in Reach for the Top, we would call it the short snappers. A quick question for Onome. Do you think that the results of your Kenyan survey on community health workers would be extrapolated could be extrapolated to other countries in sub-Saharan Africa?
That's a great question. So what I'm learning or what I'm hearing from our colleagues in other parts of Africa is that there's vaccine hesitancy. And we can also see that from the fact that vaccines, Malawi and DRC, South Sudan, issues of expired vaccines. And so the call we're getting from colleagues is we really need to start to combat vaccine hesitancy. So when you talk to people, it's the fact that the different myths around the vaccine, around AstraZeneca, that's a huge one on the continent. So around the fact that, when you get the vaccine, you might become, barren or, so the myths around the vaccine that is across the continent. I saw a video once, and this is, a video once of kids actually in school jumping off buildings, running away from the vaccine. At this point, the vaccine hadn't actually been introduced. So someone had actually doctored the videos to show that kids were running from the vaccine. And so we're finding this across many countries. So to answer your question, yes, I believe that we can extrapolate that. That is the case for a lot of countries. However, we need to also take that with a grain of salt, that the response or each community is not the same, or the things that are driving the hesitancy is not the same. So when we're responding from a programmatic level, that is one thing that we need to keep in mind.
Thank you. So we have a high-level question about financing. So in your opinion, to what extent are the current financing mechanisms for vaccine procurement undermining the goal to make vaccines available globally? In other words, are these mechanisms serving their purpose?
Is that to me or to David? Okay, David, well, I'll leave that to you.
Yeah, okay, David, you'll take it then, and Nome, you can reflect on it.
I think, again, with the realities of global politics, they're the best you're going to get right now. It's hard to do more. So I mean, that's not an outstanding endorsement, but it's right now it's as best as we're going to get. And I think as we learn more, then we might see new things which start to come.
Great, thank you. Nome, do you want to comment?
I'll pass on that one.
Okay, so as we're coming close to the end, I want to offer you up an opportunity to reflect on the experience of COVID-19 thus far, and to sort of articulate a wish list for what kind of enduring changes that you'd like to see, Nome, for example, in health infrastructure in African countries due to COVID-19. And David, how could UNICEF learn lessons from this experience to envision a robust and better response to vaccine preventable diseases in the future? So I'll turn to you first, Nome, and then to David.
Absolutely. So I think I'll quote, our global CEO, and he says, "Never waste a crisis." Right. So we've seen Africa CDC, the Africa Union, WHO, Africa region, and other institutions take this to heart from the very start of the pandemic. There's been bulk purchasing of vaccines, plans to create an Africa Medicines Agency, and invest in more domestic manufacturing of vaccines. So the Africa CDC itself, like we know, is an outcome of the 2014 Ebola crisis or epidemic in West Africa, which has made an enormous difference in the continent's response to COVID-19. So Africa would be in a better place to be prepared for the next pandemic, hopefully, than even Europe and North America. But I will say that we really, really need to invest in health systems beyond COVID-19.
Great, thank you. David?
I'm not even going to comment about reach for the top. I bet you have to know what reach for the top is in order to get a vaccine. I got mine. I hope and I believe that this is more maybe for us in North America, that this pandemic will increase global solidarity, that it is easier, when we think about the horrors that are happening right now, not in Africa, in India, to say nothing of Africa, right? I hope that we as Canadians will be able to empathize more, to recognize the interconnectedness, not only because of the fear of these mutations, the variants that come in, but also just human empathy, that what the fears that we have for our families and our communities here is just the same as that for everybody else. So I think both emotionally and I think intellectually, seeing the interconnectedness of the world, that it will lead to a more inclusive, open foreign policy, and a recognition that we need the global commons. We got to figure out how to make these global institutions work better, from UN, including ours, including UNICEF, so that we can all do a better job, because this planet is still the only place where humans live, despite what we see happening in Mars. So I hope that it'll bring us solidarity. That's what I hope for, Ross.
Great, thank you. So that's an excellent, so we're getting close to our concluding comments. So I thought I would just put a little challenge to you. Imagine that immediately after this phone call, you are given a direct line to our Prime Minister. What things would you like him to do next to improve Canada's commitment to global equity and health, and in terms of vaccine preventable diseases? Who wants to take that first? Pretend I'm Pierre.
Two things quickly.
Yeah.
One would be meet our commitments in general in ODA, 0.7%. It was Lester Pearson's idea, so it's a Canadian idea. And the second would be agree about the excess doses that we have in Canada to make those, give them to COVAX.
Excellent. Nome, what would you ask the Prime Minister?
I'll say honestly the same thing, 0.7% ODA. The second, as David said, is also the excess vaccines that we have. Give them to less able countries. France has done that, right? And I would also say that supporting the waiver of intellectual property rights. In Ontario, we've seen the advocacy by healthcare professionals calling for paid sick days and leave for essential workers. And so we see that can actually stand as an inspiration for Canadians on what we can do or how we can advocate jointly for increased ODA, as well as waivers and distributing the excess vaccines to countries that need them.
So there's great precedent for civil society organizations and others to form coalitions to affect change in global health, particularly around issues around IP and licensing and I think that would get us towards that global common good. So we've got about 2 minutes left. Any last comments or last reflections? David, from you first.
Just that it's become trite to say, but that doesn't mean it's not true. We know that no one is safe until everyone is safe. And that's just what we have to keep at the front of mind. And it be that in our own communities here in Canada, that we need to get everybody safe, or around the world. It's pretty simple. Over.
Agreed. Anome, last word to you.
Yeah, it's we need to build global solidarity around this. We can't resume life as we knew it if we have others that are still struggling from this. So I would say just the global solidarity around the idea no one is safe until nowhere is safe until everyone is.
Well, I'm going to take again editorial privilege and say I agree. I think solidarity, if the Director General, Tedros, has said it once, he's probably said it 1,000 times. And I think we need to reinforce that message, particularly as forces are making this a series of localized epidemics rather than a global pandemic. And we can't get to global access and global equity without solidarity. I think they go hand in glove. So with that, I would really like to thank you, David, and you, Onome, for a fabulous discussion. We know how many demands there are on your time, and on behalf of the Dalla Lana School of Public Health and the Institute of Pandemics and the Center for Vaccine Preventable Disease and UNICEF, I can thank you on behalf of your organization. Thank you for spending time with us today. Really, really appreciate it. To all of those who are still in attendance, this will be posted on the website if you want to watch. Please use your social media to disseminate this topic, and we look forward to seeing you at future webinars hosted by the Center for Vaccine Preventable Diseases. Take care, be well, be safe, keep sane, and be kind to each other. Bye-bye.
Bye-bye.
Bye.